and I am pleased to present you about my research. Please feel free to ask me if there anything you don't understand. The topic is comparison of the accuracy of dental implant placement using different static computer-guided implant surgery and in vitro study. The dental implant is widely used in the indentured patient. The long-term care follow-up for the 10 years. The Booster et al. Found the survival rate is more than 95%. But one of the most complications of the dental implants is malposition of the fixture and resulting to the prosthetic failure, peri-implant failure, and inesthetic. Then, the prosthetically driven design for position the implant fixture is the concept for the successful treatment outcome. The advantage of this technique are the aesthetic and prosthetic outcome, long-term stability, and to ensure optimal occlusal and implant loading. So the surgical guide is used to assist in the proper surgical placement and angulation of the dental implant. The idea of the surgical guide should accurately translate diagnostic information from pre-surgical to the direct implant placement in 3 dimensions. It should be simple and cost effectiveness, stable retention, and easy to use it. This et al. In 2017 classified the surgical guide by the method to planning. First is conventional, and another one is computer-assisted guidance. The left picture is a conventional, and the right side is computer-guided surgery. The most studies show the high accuracy in the computer guide than the conventional. So the computer-guided implant surgery can divide into 2 types, static and dynamic. In 2019, in Chulalongkorn University, they compare between static and dynamic computer guide in clinics. They show no significant difference between 2 types in static and dynamic computer guide. But in this study, we will concentrate on the static computer guided implant surgery that frequency used more than the dynamic type. This is a static computer assisted guidance. The procedure that how to produce the static computer guide, we need a 3D file, .scl file from the scanner and DICOM file from the CBCT. Make 2 files into the implant planning and production by milling or the printing, and then go to surgery. The advantage of the static computer assisted guidance are the high accuracy using in difficult anatomical position, avoid more the grafting, do it in the flaplet surgery, and maybe do the immediate restoration, but should be the verification of all parameters of the machine and need the learning curve of the surgeon and the technician. Another advantage of static guide, when we knowing the final implant position before the surgery, we can prepare a provisional restoration and do the immediate loading on the surgery day. Thangwarawut et al. In 2018, they show the accuracy of the static computer guide, a systematic review and meta-analysis. They found a deviation at the entry point in 1.2 millimeter and the deviation at the apical about 1.4 millimeter, and angle deviation is 3.5 degree. The factor that affect accuracy of the static computer guide in two phases, in pre-surgical phase, such as the quality of the data, accuracy of the milling or the printing of the guide, and design of the surgical guide. And in surgical phase, it's about the patient, the limit mouth opening, mucosal thickness, position of the implant, or experience of the surgeon. The most major brand of the implant have their own static computer guide implant system. We can categorize into two major groups that are available in Thailand market. One is a metal sleeve with a key handle, and another one is a metal sleeve without key handle. This is an example of the company that using the static computer guide, but now they're lacking study that examine the accuracy of different computer guide implant surgery, different guide design, component, protocol along the shape of the drill design that may affect the efficiency of each guide implant system. Then the objective of this study to compare the accuracy of the dental implant placement using static computer guide implant surgery between metal sleeve with key handle from the Noble Biocare and metal sleeve without key handle from the Dentium in vitro study. Now, next to the material and method. The dental implant were chosen in this study from the two companies, Noble Biocare and Dentium. Let's begin to the flow chart of this method. We made the surgical guide, bone model, and fix it together and drill and place the implant and superimposition for the deviation measurement. First, let's do the preparation of the surgical guide. The surgical guide were designed by MedMixer 3.5 software version. It's a 3D design program and printed by 3D printer by the Form 2. This is the dimension of the surgical guide in my study. In another view of the surgical guide and printed guide. Next, the preparation of the bone model. 20 bone models made from the polyurethane material simulate the human bone with cortical thickness 1 millimeter, and the rest is cancerous bone were prepared. This is a dimension of the bone model. Like this. This is a final bone model. Then we fix the surgical guide and the bone model with the cyanoacrylate superglue for bonding and metal sleeve from each company of the dental implant company. Like this. Next, experimental testing. We use the surgical guide kit from the Dentium and the Noble Biocare. I use the 5 drilling blur per model. The dental fixture size used for the Noble Biocare 4.3 millimeter and the length 13 millimeter, and Dentium we use the in the length is 12 millimeter. So it's osteotomy and implant placement. Then we remove the metal sleeve and put on the temporary abutment insertion into the implant like this, and make them to the extraoral scanner Ceramil map 600, and we will got the SCL file for the setting model like this. Next to deviation measurement. Before the deviation measurement, we need to create the reference model before superimposition. Create the reference 3D model by adding the cylinder shape like the temporary abutment, and then we print, and then we scan for SCL file for the left side for the reference model and the right side for setting model. So we superimposition by inspect software insert to the software program. The concept of the implant fixture deviation from these techniques, we use the temporary abutment represent the coronal part of the fixture and compare them by simulating the implant fixture. In the coronal part, in the distance between two dots, red dot and blue dot, and the apical deviation in number 2 and angular deviation in number 3. Next, static analysis. We use SPSS software 18 version and test normality and descriptive analysis and analyze by independent sample t-test. The results, test normality, we found the normal distribution. The results of the accuracy of the two types of the surgical guide like this. The implant placement with key handle show more deviation of the implant position than another type, except in the angulation deviation. After analyzed by the independent sample t-test, we found no significant difference in all parameters. Discussion. In this study showed there was no significant difference between two types of implant surgical guides in this study. Then the surgeon can choose the surgical guide system according to the preference. However, it showed the trend of implant position error between plan and place in the mostly parameter in slightly larger case of the surgical guide that has metal sleeve and handle. It can be inferred that more instrument used for the implant placement is more will be the error. According to Etc. et al. In 2012, they show of the most important cause of the discrepancy between place and plan implant position is tolerance among mechanical component of surgical guide resulting the error. Besides the more component of the guide of the resulting in the implant displacement, the Dilbert shape and the protocol of the drilling can more implant position displacement. In the dentium, in the right side is twist table in the shape. It can be it has the side cutting. It can resolve during the direction during osteotomy. However, in this study, we found less deviation in the angulation deviation in the surgical guide containing key handle. It could be the longer key handle in noble biocare than the dentium guide sleeve. Corresponding with the Coley et al. In 2018, is conclude that in increasing the free dealing distance leads to a significant reduction in the accuracy of the surgical guide. So our results were similar to the in vitro study done by Young et al. In 2019, but the result of my study showed lesser deviation value than the result of systematic review and meta-analysis done by Thomasev in 2018, because my study eliminated of various factors such as the bone density, mucosal thickness, limitation of the mouth opening, and other environment. And apical deviation was more than the coronal deviation than the at the apex is deviation than the coronal, because the part of the drill in the sleeve of the surgical guide which called the less deviation, the length of the drill increase, the deviation also can increase. However, the SD or standard deviation in this study is too high because of there is a limit amount of number of sample size in this study. Limitation of the study is this is an in vitro study and limit amount of sample size and eliminate various factors. Conclusion: the operator can choose the surgical guide system according to the preference. Operator can choose any that they like, that consider the factor that influence the implant deviation before using the guide, the dimension of metal sleeve, the complement of the guide, and feed dealing distance. Thank you. Oh, I'm sorry for the time. Thank you for my advisor, Dr. Pokpong Amonvit, อาจารย์ชูชัยอนันต์มานะ and อาจารย์สิริชัยเกียรติวรเจริญ and Mahidol University. Thank you.
Okay, thank you, คุณหมอพิสุทธิ์ Are there any questions regarding for this research topic? Okay, Dr. Pisut, I have one question. According to the result of this study, the accuracy of implant placement of both implant with or without key handle is indifferent. That's right?
Indifferent, yeah.
Yes. Okay. And what system would you suggest we should be to using?
I think the more instrument is more error. In my opinion or my experience, I think I will use the without the key handle, because if you have the more component, you have to concentrate two hands in the patient mouth, one hand for the key handle, one hand for the drill, and cannot to fix the surgical guide for stable. Maybe you should have the 4 hands or assistant, or because I think it's less instrument is less better deviation. Yeah.
Okay, thank you คุณหมอพิสุทธิ์ครับ